Assalamu alaikum. I am Dr. Ramisha Zahid Shah, and it's August 2023. And today we are going to talk about lymphomas again, and we will discuss follicular lymphoma today. So let's give this reactive lymph node a quick look. In reactive lymph nodes, the follicles, they are centered fairly in the cortex. They are spaced out well, and there are interfollicular T cell areas in between. Then we see a variation in follicular size and shape. And the third thing that we see distinctively in a reactive follicle is the polarization. That is the darker areas and the lighter zones. The darker areas, they are facing the T cells, the internodal T cells, while the lighter zones, they are facing the capsule. Having seen this look of a reactive follicle, now let's move towards the follicular lymphoma. As we see the slide of follicular lymphoma, the first thing that we notice is that there are uniformly sized follicles and they are scattered back to back. There's minimal interfollicular areas. And the second thing that we notice is that they are distributed in cortex as well as reaching the medulla and also effacing it. Another feature is the loss of polarization, which is one important feature that we see in reactive nodes, but it is lost over here. The follicles in follicular lymphoma are composed of centrocytes and centroblasts, and their number can vary. Besides that, we can see scattered follicular dendritic cells forming a meshwork, and then there are absent tangible body macrophages, or one can spot very rare tangible body macrophages, but they are not seen prominently as are seen in the germinal centers of a reactive lymph node. So how do we grade a follicular lymphoma? For grading of follicular lymphoma, we have to see the number of centrocytes, the number of centroblasts, and we compare them to the centrocytes. So grading, here's a word of caution that now in new WHO 2022, grade 1 and grade 2 are not recommended, not required, I should say, because of the inter-observer variability. Anyways, there were up to 15 centroblasts per field in grade 2, but it's not recommended anymore. And for grade 3, which was divided as 3A and 3B, having more than 15 centroblasts with or without scattered centrocytes, they are now, the second thing that we have to notice when we see so many centroblasts is the pattern that is either it is follicular or if it is diffuse. So now we also have to look at the percentage of patterns. So if there's follicular pattern in more than 75% of our specimen, we call it follicular lymphoma. So we can have a follicular lymphoma that is, by this definition, if it is composed entirely of centroblasts, yet it takes a follicular pattern, we will still call it a follicular lymphoma. And then we have the gradual increase in the diffuse areas. And finally, there's diffuse pattern in which there is absence of follicular areas. And we take that as DLBCL, diffuse large B-cell lymphoma, specifically that is composed of centroblasts. And the centrocytes are not seen or minimally seen. Then we treat it like a DLBCL, diffuse large B-cell lymphoma. IHC. So what's the IHC over here? It's a CD20 positive lymphoma. It's a B-cell lymphoma. So the cells are going to stain for CD20. Its germinal center markers, CD10 and BCL6 are positive because it is originating from the germinal center centrocytes and centroblasts. So they are going to stain for CD10 and BCL6. BCL2 is positive, strongly positive, I would say. BCL2 is strongly positive in follicles. And this is the word of caution over here that BCL2 is actually negative in the germinal centers of a reactive lymph node. And hence BCL2 here, it is the pattern of BCL2 staining that is helpful in follicular lymphoma. That it is not just staining the background, but also giving a very, very strong staining to the follicles, which is not seen in reactive lymph nodes. As you can see in this schematic diagram, that BCL2 is negative in germinal centers, in a reactive lymph node, while it is strongly positive in follicles of a follicular lymphoma. Another strange marker is Ki67 in follicular lymphoma. Ki67 is usually very much high even in the reactive follicles because they are rapidly dividing. So Ki67 is very high in reactive follicles. But if we look at the follicles of follicular lymphoma, Ki67 is low. And this is a very unique finding for follicular lymphoma. Other markers that we can use are to rule out T cell. We are going to use our T cell markers to rule out T cell lymphoma, and CD5 is negative and cyclin D1 is also negative. And using cyclin D1 and CD5, we are ruling out the other small cell lymphomas that we discussed yesterday. That was CLL, SLL, and mantle cell lymphoma. Now, there are some high yield points for follicular lymphoma. It's an indolent neoplasm, but it presents as a widespread disease, usually stage 3-4 disease. The median age is it is also a lymphoma of old age, and the median age is 60 to 65 years. Molecular translocations are very important here in the diagnosis. It's T1418 involving the BCL2 gene. That's why it's seen. What are the poor prognostic factors here? Okay, high histologic grade, that is the number of centroblasts. Then if we see diffuse areas in more than 25% of the specimen, then with the predominance of centroblasts, this is another poor prognostic factor. High proliferation index, if it's more than 40%, we start treating it as DLBCL, large B-cell lymphoma. And then if there's presence of BCL2 along with MYC rearrangement, it's a poor prognostic factor, and also the presence of PP53. Let's not forget the morphologic variations. There's a very nice floral pattern, and this floral pattern, it resembles PTGC on its microscopic appearance, and the signet ring pattern. There are beautiful signet rings that are seen, and the important differential is with metastatic signet ring carcinoma. Of course, IHC is very helpful in ruling out the metastatic disease. The follicular lymphoma doesn't end here, by the way, and we have follicular neoplasia in situ as well. It's not an HNE diagnosis, and we can diagnose it based on the strong positivity of BCL2 and CD10. And the B cells, the centrocytes, are confined to the germinal centers. So it's an incidental finding, and then we cannot diagnose it on HNE. Ki67 is also low in the germinal centers, and we can diagnose it just by using IHC, and also if we can do some molecular studies on it. Next is the pediatric type follicular lymphoma that needs a mention over here because of its very pretty follicular pattern. There must not be any diffuse areas. It has a very high-grade morphology, resembling centroblasts, though they are not actual centroblasts, but still, it's indolent. That's the one good thing about it, that no matter how scary looking it is still an indolent neoplasm, and it is seen mostly in head and neck region. There's no age cutoff, and usually it's considered less than 40 years of age. We can see it, though the cases are seen in commonly in pediatric population. Then there are no translocations of T1418, MYC, or BCL6. The Ki67 is high and BCL2 is negative, but the pattern is amazingly follicular, and it's commonly seen in head and neck, also seen at other sites. So there's another list of follicular lymphomas. There's duodenal type follicular lymphoma, which has excellent prognosis. There's a diffuse variant. Then there's a testicular follicular lymphoma, which is very much like pediatric type follicular lymphoma with good prognosis, and also seen in younger age. Then there's primary cutaneous follicular cell lymphoma that we will discuss when we are doing our cutaneous lymphomas. And unusual morphologic patterns of follicular lymphoma, which is Castleman-like, EBV positive follicular lymphoma, and there's quite a list of it also. So what are the differentials for follicular pattern? If we see follicular pattern on H and E, what are our differentials? First important differential is the reactive lymph node. The reactive lymph node we have discussed earlier, based on the size of follicles, their location and their polarization, we can distinguish it. BCL2 will be positive in follicular lymphoma, while negative in the germinal centers of a reactive lymph node. PTGC, it is an important differential for the floral variant. However, the in PTGC, the nodules are 3 to 5 times larger, and then there's a good background of reactive follicles. Again, IHC and molecular studies are going to be really helpful over here. Nodular lymphocyte predominant B-cell lymphoma, another lymphoma with follicular pattern. However, IHC and molecular studies are different, and we will discuss it in detail when we are doing Hodgkin lymphoma and this and differentiating it from NLPPL and follicular lymphoma. Nodal marginal zone lymphoma. Actually, this lymphoma is notorious for colonizing the existing follicles. So we must use IHC judiciously and also molecular studies to differentiate them both. And last but not least, nodal T follicular helper cell lymphoma follicular type. I have just put it in the list. It's a T cell lymphoma, but the pattern is follicular. So if we see a follicular lymphoma-like pattern, but and again, it's a helper cell lymphoma, and it's from follicular origin, so it is going to be positive for BCL6 and CD10. But if the abnormal population is not taking B cell markers and rather taking T cell markers, we must immediately think of this entity, that is nodal T follicular helper cell lymphoma follicular type. So we end our discussion over here, and thank you for listening.